So again, I'm Lieutenant Commander Brandon Johnson with SAMHSA's Office of the Chief Medical Officer, formerly of SAMHSA's Division of Pharmacologic Therapies. In the Division of Pharmacologic Therapies, most of our work surrounds the regulation of opioid treatment programs, the model that provides methadone to patients and buprenorphine, as well as the data waiver practitioners. So today I'm going to talk to you about the continuum of care for providing MAT in the context of telehealth. Start out by describing the problem. I don't think I like this very much. So, there we go. All right. So of course, we talk about the opioid epidemic. I know you've heard all that data probably earlier today, but the most recent survey, National Survey of Drug Use and Health, indicates that about 12.5 million Americans, or about 4.7% of the population aged 12 or older, are currently misusing a opioid pain reliever. Of course, that's accompanied by significant increases in opioid overdose. If I can get the clicker to work right. Pardon, if you bear with me for 1 second. So in 2015, there were also 22,000 deaths involving a prescription opioid. That's equivalent to about 62 deaths per day. This is an increase from the 2014 number. So over the course of the last few years, every year it's gotten higher. So in 2014, there were 19,000 deaths. A significant portion of the increase in deaths involve synthetic opioids other than methadone, such as fentanyl. So if you'll see the trend line, of course, we're going up, 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 up. Doesn't seem to be any plateau at present. And that's also accompanied by a lack of treatment resources, i.e. capacity. So if you look at the data here, this is from a recent study by Jones, Campopiano, Baldwin, and McCants, all of which are or were feds at the time of the article was drafted. The blue line indicates the current rate of past year opiate abuse or dependence. The red line indicates the current capacity we have in terms of office-based treatment. This is how many patients we could theoretically treat with the number of physicians that we have currently data waivered within the country. And bear in mind that that's a theoretical capacity. That's not, most physicians don't actually prescribe. So the rate is much of, our actual capacity is much lower than that. And the final, okay, thank you. Thank you. And the bottom line is the number of patients that have been treated in opioid treatment programs, i.e. What used to be known as methadone treatment programs, over the course of the last 10 years. So we've got a significant way to go in terms of being able to provide care to the population of individuals who are in need of treatment. I think it's also important to mention, I covered it briefly, I think Dr. Weintraub did also, what the treatment system looks like for providing care for an opioid use disorder. We, of course, have opioid treatment programs that are able to provide methadone and buprenorphine. This is a much more, you could think of it as an intensive outpatient treatment, typically, but there's also inpatient treatment facilities, residential facilities, detox facilities that are also registered and certified by SAMHSA to provide this level of care. We have waivered physicians, data 2,000 practitioners, of which Dr. Weintraub is. So that's the OBOT doctors, the ones who can prescribe buprenorphine only presently, or who are legally allowed to prescribe buprenorphine for the treatment of an opiate use disorder. And then we have other non-regulated providers. That's your drug-free programs, or providers that provide Vivitrol or naltrexone is the generic name for care. Those providers are not regulated by the federal government at all. This is the ASAM PPC. This kind of describes what the continuum of care is for treating an opiate or any substance use disorder, frankly, ranging from 0.5, which is, the continuum was numerically oriented. So 0.5 is an early intervention, all the way up to number 4, which is medically managed intensive inpatient services. So think of this as the intensity of, or the severity of the substance use disorder increases, the level of care would also increase for that patient. That's a generalization, but that's the way you kind of think about it. But you also bear in mind that the patients with a real severe use disorder may not necessarily be appropriate for the highest level of care, because those are also going to be your patients that are going to have that may have a lot of comorbid conditions. They may have endocarditis, or they may have there's some other skin conditions or other infectious diseases that go along with injection drug use. And if those patients require other medical services, they may not necessarily be able to provide those in a substance abuse treatment facility. So there has to be some individualizing of the treatment approach for each patient, because you have to meet the patient where they are. So also in federal regulation, we kind of outline what the critical components or standards of care are for this patient population. Individualized assessment and treatment plan, which I just mentioned, should include, the standard of care, frankly, is methadone or buprenorphine or Vivitrol. In other words, an FDA-approved medication for an opiate use disorder. But that is also an individual decision between the patient and the physician. Maybe the patient doesn't necessarily feel they want to use an opiate, a medication to treat their opiate use disorder. While we always recommend it, that is also a very personal decision for that individual, and it should be carefully considered with that patient's physician. Psychosocial or substance use counseling services, infectious disease risk assessment and counseling services, substance use testing or drug testing. That's a clinical tool to assess outcomes, essentially. Is that patient reducing their substance use? And that, we can always rely on self-report, but it's better to have an objective measure, of course. And then prenatal care, if applicable. These treatment elements or components are actually required in opioid treatment programs. OBOT doctors provide attestations that they're going to provide some of these services, along with office-based care, specifically psychosocial services, as well as substance use testing. But the system is a little bit different. It's not as heavily regulated, so it's not a specific requirement, although it is the standard of care. So in terms of treatment, we also think of treatment as a prevention approach as well. Of course, if you are treating the addiction, you also have, there's going to be better outcomes for other conditions related to that use disorder, specifically infectious disease, Substance abuse treatment has shown to improve adherence to the medications related to HIV care as well as hepatitis care. So, of course, we always want to continue encourage that patient to engage in their in substance use treatment if they have an identified use disorder and co-occurring or infectious disease. Obviously, engaging in treatment is going to reduce the likelihood that that patient has an overdose. The current literature actually indicates that engagement in treatment reduces risk of overdose. Some studies have found that it's the overdose risk is reduced by about 50%. Okay. And also, medication-assisted treatment is indicated for pregnant women with an opiate use disorder and recommended by the American College of Obstetrics and Gynecologists. However, you have to balance that. So, because, of course, with methadone and buprenorphine, that is an opiate medication. It may, the patient, the neonate may still be born with a neonatal abstinence syndrome. However, when you think about the maternal-child dyad, that the health of the mother is going to be overall improved overall if she's engaging in substance use treatment. So that medication is important for stabilizing mom, so she's not using maybe substances that are a little bit more dangerous for her and her baby. So, and then you can always treat that neonatal abstinence syndrome once mother delivers. So, and it's going to improve the health of both mom and baby. So overall, engaging in opiate use disorder treatment, specifically medication-assisted treatment, reduces all causes mortality. So I'm going to move quickly because I got 5 minutes left. SAMHSA efforts. So, of course, we're doing an internal federal collaboration. We're working across the aisle with our partners over at HRSA and other people within the department to encourage the use of telehealth. We're looking at ways and how we can be supportive to expanding capacity, specifically via telehealth. We also are developing products and guidance for the field related to telehealth. Currently under development is a telehealth toolkit for medication-assisted treatment providers. We recently did a SAMHSA mobile app challenge with to develop a recovery-oriented app for patients with an opiate use disorder. I think the winner of that challenge was an app called FlexDeck for MAT. It's actually available in the App Store as well as the Google Store. We're also been doing some environmental scans. Actually, that's one of the reasons why we did the app challenge. We did an environmental scan a few years ago and found that while there were several apps specific to substance use disorder recovery, typically they were focused on alcohol. There were none focused on opiate use disorder. So we decided to do this app challenge and encourage some innovation in this space. And now there's about 10 or 15 apps in the marketplace. So that was an initiative we took on with our, I guess you would call it kind of our health IT division, and was very successful. Some other products that SAMHSA reflects the continuum of care, especially for opiate use disorder, is TIP 40, TIP 43, and the federal guidelines for opioid treatment programs. TIP 40 and TIP 43 are kind of more specific clinical guidance to how do you provide care to this patient population, especially in the context of a medication-assisted treatment program, opiate treatment programs using buprenorphine or methadone, and then of course buprenorphine for TIP 40 when you're providing care in an office-based setting. The federal guidelines for the opioid treatment programs describes kind of how SAMHSA envisions its guidance to the field on how opiate treatment programs should be operating. essentially. And there is guidance in that document as well on the use of telemedicine to treat an opioid use disorder with a medication. Also, there's 2 other technology-assisted care documents in SAMHSA's store, specifically considerations for the provision of e-therapy, so providing counseling and psychosocial services via telehealth or technology, as well as using technology-based therapeutic tools in behavioral health services. These don't really speak to the use of the medication, but they for treating an opioid use disorder, but they are helpful documents if you're thinking about expanding care to this population, and items for consideration that you need to examine carefully when you're considering providing care. I think my slides will be available, so you don't have to take pictures, and I'm happy to email them to anybody who needs them. So those are some documents that are available in the SAMHSA store presently, and you may want to think about reviewing in thinking about this. Finally, what are the opportunities? I think providing access to care in health professional shortage areas, both rural and urban. Yes, Western Maryland or the Eastern Shore are geographically dispersed areas without a lot of providers, but there are also areas that are urban and densely populated that may need additional providers as well. Baltimore is a perfect example of that. There are not enough maybe in certain neighborhoods there's enough providers, but Baltimore is actually thought of as a health professional shortage area, if I'm not mistaken, as well. And there are other areas that are urban that have the same issue. So we need to consider that just because it's urban doesn't necessarily mean that telemedicine, it doesn't present an opportunity to provide or expand access to care in this environment as well. Providing support to professionals on how to treat substance use disorders and opiate use disorders. Specifically, I don't know if you've heard of the something called the Telehealth model. It's been very successful in providing training to and hepatitis care. And what they found is that using this model, non-specialist providers were actually able to achieve similar outcomes to specialty providers providing care for hepatitis. So we're trying to duplicate that for substance use disorders and some other behavioral health conditions, and providing care to non-specialty providers, and how to bone up their skill set or their toolbox for providing care to this population. And then provide tools for individuals with a substance use disorder to support their own recovery efforts. I spoke about the marketplace of apps and now how it's exploding over the course of the past few years. There's, I think, a great opportunity, if not to provide direct clinical care, but certainly to support these individuals in their goal towards recovery. So, and finally, some questions for consideration. What does opiate use disorder treatment via telehealth look like? That's a question it's a moving target, essentially. As we think about care in this model, you know, Dr. Weintraub talked about the Ryan-Haight Act. There's some regulatory considerations that we need to flesh out, because it's kind of a gray area, if you will. It's very unclear how care is going to be provided in this model, how we can expand care, because we're looking for more additional regulatory guidance from our other federal partners on that. How do we support broader dissemination for telehealth for substance use disorders or opiate use disorders specifically? And what are the broader regulatory and policy considerations for providing care in this medium? So those are just some things to think about moving forward. So again, I'm Lieutenant Commander Brandon Johnson with SAMHSA's Office of the Chief Medical Officer. My information is up here. I'm sure the slides will be available if you need them, and I'm available for questions if you have them.